Guys, good morning, everyone. Today we are going to talk about MR spectroscopy. What is that? First, the definition of MRI spectroscopy, it is a non-invasive diagnostic test for measuring the biochemical changes in the brain, especially in the presence of tumors. What we do here is to measure the concentration of different metabolites in different areas of the brain, okay? And analyze them to see what are these changes. So while the MRI, the conventional MR exam, identifies the anatomical location of the tumor, the MR spectroscopy compares the chemical composition of normal brain tissue with the abnormal brain tissue. What are the chemical changes difference? This test can be used to detect soft tissue changes in stroke, epilepsy, and other applications. It can be identified, in fact, be performed with many different nuclei in the brain. There is the hydrogen, the phosphorus, and then there have been reports on spectroscopy of dendridium, carbon, nitrogen, lithium, sodium, fluorine. All of these, till time being, is just on research purposes. The main use till now is for the hydrogen spectroscopy. It's only, the only clinically approved spectroscopy is for hydrogen. So it reveals the disturbance is associated with the neuronal and axonal degeneration, demyelination, and even compromised liver function. Very important point. It is a complementary exam to MRI. It is not an exam by itself. You can never, ever interpret spectroscopy alone without conventional brain MRI. You never, ever see the spectroscopy alone, always with the MRI images, okay? It can be used to monitor the therapeutic trials, and it's more sensitive than MRI for detection of neuronal damage. And it's useful in differential diagnosis, not for diagnosis, just differential diagnosis. So, what we mean by more sensitive than MRI for detection of neuronal damage, that is, in the conventional MRI, you see areas that appear normal to you. While when you do MR spectroscopy, it will reveal that there are some abnormalities in these normal looking areas, okay? For example, in tumors, as we said previously, the tumors usually spread beyond the mass that you see. And that's when spectroscopy will be helpful. It will show you that normal areas of a brain have abnormal chemical composition suggesting tumor. So, we have some bad news here. The MR spectroscopy allows the tissue to be interrogated for the presence of concentration of various metabolites, but Grossman and Yusim said, if you need this to help you, go back to page 1. Everything except Caravan has low NAA and high choline. All diseases except Caravan disease, they all have low NAA and high choline. So if you need spectroscopy to have a diagnosis, you don't know anything. You have to go back to the first page, okay? So, although this is little harsh, but it's fair to say that MR spectroscopy does not add a great deal to an overall MR study, but does increase specificity and may help improve our ability to predict histological grade. So, it does not add anything to the diagnosis, it does not add anything to the detection. However, it increases the specificity a little bit because everything increase choline and decrease NAA. This is N-acetyl aspartate. So, how it's done? There are differences between the magnetic properties of different tissues or tissue air boundaries, causing inhomogeneity in the magnetic field, resulting in broadening of resonance. This means that different tissues, they resonate at different frequencies, okay? So what we do here is we measure these frequencies. In order to do that, first rule, we need to have very good shimming. Shimming is having as much as possible homogeneous magnetic field, okay? You need a magnetic field that is very homogeneous along the machine. And we can do that either manually, the engineers come and do shimming and calculation, I don't know what, okay? Or there is, in the machine, there are settings that do auto shimming, Okay, so you need very good shimming to have a very good spectrum. Otherwise, you'll have a bad spectrum. And a high order shimming requires a higher field. Yani 3 Tesla images will give you more better images with better shimming. Okay, shimming. Sometimes I say just like the car balance. You need to make a ميزانية or balance to have the car goes straight way. You do ميزانية or balance for the MRI. Okay. The problem is the concentration of water is about 10,000 times the concentration of other metabolites. So when you have MR spectroscopy done with the water present, you will have a curve like this. This is just a second. This will be a water peak, and all the other metabolites like this, useless. So what we need to do is to suppress this water in order to get a better look at these metabolites. So this is done by the machine. We don't do it, but the idea is we remove the water in order to see the rest. What are the challenges of the clinical MR spectroscopy? First, there is the millimolar concentration of brain metabolites. We are talking about very, very low concentrations that need to be measured. You need to suppress water, you need to suppress fat signal, and there is different composition of the brain, gray matter, white matter, they go in, combined between each other. And the localized spectra, you need spectrum from different areas of the brain. So you have single or multiple voxels or volumes. And there are difficulties in absolute quantification of the spectra and the quantification relative to unchanged metabolites. Things to consider when interpreting an MR spectroscopy. Always correlate with the clinical morphological data. Several pathologic entities are impossible to differentiate by MRS alone. Always consider age, concentration differences. Various metabolites have different concentrations throughout the organ, like in brain, prostate, and they vary with age. So again, you never ever interpret spectroscopy without having conventional brain MRI. This is the golden rule. Okay? Don't forget that. So when you interpret a spectrum, you should consider other diseases, like, for example, liver that causes decreased myoinositol, decreased choline. Drugs like antibiotics might change the spectrum. Technical problems, artifact, for example, in poor shimming, you'll have a bad spectrum. If there's poor water suppression, motion artifact, if there is contamination, for example, by bleeding, you'll have abnormal spectrum. What is used for mainly? It's used for space-occupying lesions, epilepsy, demyelinating disorders, neurodegeneration like dementia and Parkinson, and metabolic disorders, which are in general rare. So, for example, you see here a patient with acute right middle cerebral artery stroke. There is a normal spectrum, B, A, and B is abnormal spectrum. What do you see here? You see the choline, creatinine, and AAA, N-acetyl aspartate. And again, you see here, you notice the normal part showing high NAA, while it's decreased in the abnormal part. And there is this peak, the lactate peak, indicating anaerobic metabolism, okay, in this part. So, there are multiple different metabolites. Each one has its own concentration, has its own resonance frequency. You read it as certain part of the spectrum. The most important ones are these: the lactate, the lipid, the alanine, N-acetyl aspartate, glutamine, GABA, creatine, choline, and things like that. Okay, we'll talk about them in the following slides. This is a table showing different metabolites, where they increase, where they decrease, and how to interpret them. Anyway, it's a very long table. We will not go into it. We'll go into different metabolites one by one. First, the N-acetyl aspartate, it's the largest, gives you the largest metabolite signal, resonate at 2.02 part per million. It's predominantly in the neurons, axons, and dendrites, okay, of the central nervous system. So NAA indicates neuronal tissue. When it's increased, there is increase in neuronal tissue. When it's decreased, there is decrease in neuronal tissue. In the MR spectroscopy measurement, it appears one of the best surrogate markers currently available for neuronal integrity. When it's normal, the neurons are normal, are intact, okay? And normally it should be between 2 to 2.5 times the peak of choline, okay? For example, you can see here, this is a case of acute demyelinating encephalomyelitis, and you can see the this voxel in the abnormal area shows very low N-acetyl aspartate compared to choline. Creatinine, we said it should be 2 to 2.5 times the peak of choline. Okay, after treatment, you can see there is a marked increase in the NAAB, indicating recovery or integrity of the neuronal tissue has been restored. Regarding choline, it resonates at 3.24 part per million. It involves the membrane synthesis and degradation. So when there is choline, there is membrane. Increased choline, increased membrane. Decreased choline, decreased membrane. Okay? Elevation of choline signal indicates active demyelination, resulting from degradation of myelin phospholipids or increased number of glial cells. Low choline been observed in hepatic encephalopathy, causes decreased choline, while elevated choline seems to be characteristic of many types of neoplasms, including high-grade brain tumors, prostate, breast, head, neck, and others, because neoplasms have more cells indicating more membrane, so the choline will increase. Okay? Creatinine, it's used in energy metabolism. Since creatinine is synthesized in the liver, it's not synthesized in the brain. So chronic liver disease leads to low cerebral creatinine concentration. Okay? White matter creatinine levels are lower than those of gray matter in the normal brain. The voxel in the white matter will give you lower choline than in the gray matter. Okay? It has been suggested that creatinine is relatively constant in the human brain. For this reason, creatinine is used as a reference signal. Usually, most of the time, not all of them, most of the times, creatinine will be fixed. It will not increase or decrease because it's synthesized in the liver. It's not in the brain. Okay? So, we use creatinine to correlate other metabolites. If the Na increased relative to the creatinine, decreased relative to the creatinine, and so on and so forth. Okay? Lactate peak, normally lactate is below the limit of detectability. Normally, you do not see lactate. Any detectable increase in the lactate can be considered abnormal. The increased lactate is usually due to result of deranged energy metabolism, yani anaerobic metabolism, loss of oxygenation, no oxygen leading to anaerobic metabolism causing increased lactate. Okay? You know, when you play sport for the first time, the muscle will start to be so painful because the muscle does not get enough oxygen, goes into anaerobic metabolism to get energy, producing lactate. The same thing happens in the brain. The brain will have not enough oxygen, for example, a stroke or any other condition that decrease oxygenation of the brain. The brain will go into anaerobic metabolism, start producing lactate. Myoinositol observed at short T's. One of the largest signals occurs from myoinositol is at 3.56 part per million. It's a sugar, pentose sugar. Levels have been found to be reduced in hepatic encephalopathy, increase in Alzheimer's dementia, and demyelinating disease. Okay? The exact pathophysiology is uncertain. Glutamate and glutamine, they are amino acids. They are often labeled as composite peak of glutamine. They show together. One peak showing glutamine and the glutamate together. So its increased has been found in patients with liver failure, hepatic encephalopathy, and Reye's syndrome. Now, some technical issues. We have two types of sequences. The first one is called STEAM, and the second one is called PREST. We have two techniques, single voxel and multivoxel. Single voxel means short scanning times. You put one voxel on one area of the brain, and the machine will give you the spectrum of that area. Multivoxel, you make like a grid for the whole brain, and the machine will give you the spectrum for each voxel of the brain. This, of course, is much more beneficial, but it needs much longer time. So the time is a problem here. For example, here, this is a young patient with mesial temporal sclerosis. There is increased choline and creatinine and low NAA. You can see this NAA, choline, creatinine. You can see in the abnormal part of the brain, there is decreased NAA and increase in the choline, while the creatinine, little bit increased, although we agree that it should be constant, okay? These are features typical of glioma and atypical for mesial temporal sclerosis, which usually shows selective reduction in the NAA only. So when we see increased choline here, there is more membrane. There are more cells. Why? It should be some sort of tumor. Okay? It's not just straight epilepsy. Epilepsy should cause decrease in the neuronal integrity, which manifests as decreased NAA. So normal, usual epilepsy, conventional routine epilepsy should show just decrease NAA. When there is an increase in the choline, there is something wrong here. We need to interpret it with the MRI images to show what's wrong. At birth, the neurons are not fully formed, so the NAA should be low, while choline and mannitol are high. And over the first 1 to 2 years, there is a gradual normalization toward adult value. So if you have a child that less than 1 to 2 years, you should have low NAA peak. With time, as the child grows, after 1 to 2 years, the NAA will start to normalize. So, what are the changes in the MR spectroscopy with the brain development? First, the NAA choline increased rapidly from 0 to 1 year. Okay? The NAA become dominant peak by 6 months. And the NAA choline ratio of 1.5 to 1 is completed by 1 to 1.5 years. 2 to 1 or 3 to 1 in adults. Okay? So, starting with low NAA and with the increasing age, the NAA will start to become the more dominant peak. The choline creatinine ratio decreases from 0 to 2 years, okay? Because first the choline is high, then the choline will start to normalize. Okay, what about here? What do we have here? There are high levels of choline and mannitol at the earliest time point, which declines over the first 2 years. You can see these are 4 days, 5 months, 4 years, and into adulthood. You can see the NAA is low, and it starts to increase with age, okay? The NAA peak is low, there it's more, okay? And you can see this is in the occipital gray matter, in the parietal white matter, the same idea. The NAA starts low and then increase, okay? And the choline and creatinine ratio, first the choline is high and then it starts to decrease and to normalize, reaching the adulthood, okay? Because the membranes are more in the child, their brain is forming. After it's well formed, the choline will start to decrease. Now, MR spectroscopy in space-occupying lesions. What it can be used for? It can be used for differential diagnosis, for histological grading, for stereotactic biopsy. You can tell the surgeon this part of the brain is abnormal, go biopsy from there. Okay? Differentiation of tumor recurrence from radiation necrosis. What are the consistent findings? First, we have decrease in AA because in the tumors derived from other than neuronal tissue. Okay, the NAA will decrease because it's a marker for neuronal integrity. The choline will increase due to increased cell density, increased membrane, increased gliosis. Sorry. Lactate and lipid will increase due to anaerobic metabolism. Alanine increase suggestive of meningioma. Alanine, when it's increased, it's more in favor of meningioma. For example, you can see here, what do we have here? There's a mass lesion. This mass lesion is peripherally enhancing, necrotic tissue. It looks like a glioma, okay? Now, when we do spectroscopy for this mass lesion, you can see the following. In the area number 1, this here, you can see the NAA is decreasing, indicating a tumor infiltration. Okay? In the area number 2, that's here in the center of the lesion, the necrotic part, you can see a high lipid peak, indicating necrosis, anaerobic metabolism, okay? And very low NAA compared to choline and creatinine. Okay, together until now? In the area number 3, this part here at the periphery, again, you can see high lipid with very low metabolites, indicating necrosis, no cells, okay? While in the area number 4, that's on the opposite, on the contralateral hemisphere, you can see there is NAA normal, choline normal, creatinine normal, indicating normal brain tissue. So you can, for example, if you want to suggest a part of this tumor to biopsy for the surgeon, obviously it will be in area number 1, the area that has tumor infiltration and no necrosis. So it will be more histologically يعني more diagnostic. Okay, and you can see here in this mapping that there's an increased the map of changing the NAA style as parted. You can see there is increase in the NAA at the lesion, at the area of the lesion, indicating high neuronal integrity has been disturbed. Again, you can see here this is a multivoxel image, and you can see at different parts of the image that there are different changes in the spectrum. Unfortunately, it's small, and I don't know whether it's obvious or not here, but you can see an increase in the lactate peak here and here and here, and there is virtually no NAA peak. Okay, you can see here, this is a spectrum also showing a very low NAA peak, high lactate peak, and decreased elevated choline relative to creatinine. So what do you think what's going here? The lactate peak is high, the NAA is low, the choline is high, indicating tumor. There is a tumor here, definitely. Okay? Why lactate? Why loss of NAA? Why increased choline? There is high cells with low neuronal integrity and anaerobic metabolism. This goes with tumor. Okay? Regarding tumor grading, you can see there is a mass here, okay, bulging into the lateral ventricle, and when you take different spectra from different parts, for example, you can see here the NAA peak is low and the choline is high, indicating that there is high cell proliferation with low neuronal integrity. This is a high-grade tumor, okay? Again, you can see here the normal part showing the NAA, the normal, and the choline peak. Okay, compare this with this. The NAA is high, while here it's low. Okay? Again, for tumor grading, you can see different cases, different spectra. What do we have here? Low NAA, okay? Choline and creatine are relatively normal with very high lipid lactate peak. Again, different mass, different tumor, different patient. Very low NAA, increased lipid and lactate peak. All indicates high-grade tumors. The NAA is high, the NAA is low, it means loss of neuronal integrity. Choline is high, indicating proliferating cells, increased amount of cell membrane. Okay till now? Good. Now, can it help us decide whether this tumor is a primary or a metastasis? Of course. You do spectroscopy for the periphery of the lesion, the primary tumor infiltrate, metastasis does not infiltrate. You do spectroscopy for normal-looking areas adjacent to the mass. When you have a primary tumor, the primary tumor will infiltrate, will show you abnormal spectra, while metastasis does not infiltrate, will show you normal spectra. Get it? Let's see now here. For example, this is a follow-up spectrum for brain lesions. First, before treatment, you have a low NAA, just like we said previously, increased choline, markedly increased choline, and a very high lactate and lipid peak. After treatment, you can see the NAA still low, the lactate and lipid is starting to decrease. Okay? Choline is even more elevated. So this is indicating no response to treatment. The tumor is still proliferating fast. Okay? So, now let's do this, some sort of fast quiz. Is this normal or abnormal? Abnormal. What's the abnormality you can see here? High peak choline and low NAA. So, this should indicate what? First of all, you never ever interpret a spectrum without having a normal brain, the conventional brain image. Okay? This is the brain MRI. What do you see here? This is the child, which has normally low NAA and high choline. It's, in fact, it's an infant, not only a child. It's very low age. So you normally expect to see a low NAA that increases with time, while choline is high and decreases with time. This is a classic trick. You never interpret spectrum without having a brain MRI. Okay? So, this is another case. Is it a radiation necrosis or a recurrence? Anyway, this is, I don't think it's very well, the low resolution, unfortunately. However, we can see in this spectrum, this is the choline, it's high, NAA is low. And you have this lactate peak. So, what do you think? Is it radiation necrosis or a recurrence? It's a recurrence because you have high choline indicating proliferating cells, a lot of membranes, and the low NAA indicating loss of neuronal integrity, while the increased lactate peak indicating anaerobic metabolism. Okay, while if it's necrosis, you should not have an AAA peak because it's necrosed. Okay, and you should not have a choline because you don't have cells, it is necrosed. Okay, again, another case. Is it primary or metastasis? You have a solitary brain lesion. What do you see here? You see this choline peak, you see this NAA. In which part of the brain? At the periphery of the lesion. Okay? When you have a low NAA, indicates what? Indicates loss of neuronal integrity, but there are some residual neuronal cells. Okay? Metastasis should not have an NAA peak because it's not from the brain, it's from somewhere else. Come on? Get it? Metastasis from the lung, from the colon, from breast, from I don't know what. Anyway, it's not neurons, so it should not have an AA. When you see an AA, this is from the brain, indicating primary brain tumor. Okay? I have this lesion here in the brain. Is it a tumor or is it an abscess? What do you think? You have succinyl, you have lactate, you have why? There is no NAA. It's not a brain tissue, okay? And there is no choline, there is no creatine, there's nothing. All different weird metabolites that we have never heard of, indicating this is an abscess. It is part of the brain that has been completely destroyed and replaced by pus, okay? And of course, the imaging features can be used to suggest an abscess, thick-walled lesion with peripheral edema and mass effect and things like that. Another case, this is a middle-aged female with sudden onset of aphasia. The differential diagnosis was demyelinating disease, abscess, glioma, or metastasis. Spectroscopy was done here and it shows increased acetate, anestal acetate, lactate peak, okay, here, increased. So what do you think is going on? This is acetate peak, sorry, not anestal aspartate. Acetate peak and lactate peak. What do you think is going on? This is an abscess because the lactate peak is increased. There is no NAA, there is no choline, there is no creatinine, indicating this is not a tumor, it is an abscess. It's not even from a primary brain abnormality, okay? It's not a glioma, it's not a demyelinating disease, and metastasis and abscess. Metastasis should not have lactate peak, or at least not that much increase. Abscess is more, give you more peak of lactate and lipids. Exactly, other metabolites should be seen. Yeah, different types of amino acids should also be seen with abscess than with abscess than with metastasis. Metastasis is not from the brain. You should have a spectrum that's no one can understand it. It's different metabolites no one heard of. Okay, sorry. Choline in metastasis due to increased proliferation might be seen more even than abscess. I agree. Anyway, so it has some applications in epilepsy. It can be used to identify and localize the structural substrate that underlies seizure disorder. It can determine the functional significance of an epileptogenic tissue and identifies patients suitable for surgical treatment and provides surgical planning and guidance and characterize regional cerebral neurometabolic profiles associated with seizure disorder. So, the sensitivity of MRI in detecting substrate of epilepsy, in case of a tumor, the MRI should be 100% sensitive. In vascular malformation, MRI should be 100% positive. In MTS, up to 95%, and in destructive injuries like trauma, infarction, or infection, should be between 80 and 90 degrees. This is the MRI, not the spectroscopy. So you should have an MRI image with the spectroscopy always. While MRI spectroscopy with epilepsy should have changes in the levels of NAA, choline, and creatinine, some lactate, some amino acid neurotransmitters like glutamate and GABA. So what are the findings in epilepsy? Epilepsy causes decreased blood flow to certain parts of the brain, the epileptogenic focus, resulting in decreased NAA and decreased choline and creatinine due to gliosis. Okay? Should have some increased lactate due to interrupted blood supply going to anaerobic metabolism, and decreased gamma aminobutyric acid, which has a role in suppressing the origin and the spread of the seizure. Decrease in poor seizure control, yani in uncontrolled epilepsy, the GABA should be lower than normal. Single voxel technique needs previous data on the location of the focus. You should know where is the focus in order to put your voxel there. Chemical shift imaging provides you with a large region of is excited, and the metabolite signals from both temporal lobes can be compared. You compare both right and left and to see which one is abnormal. Regarding MTS, there is neuronal loss affecting the pyramidal cell layers of the cornu ammonis of the granular layer of the dentate gyrus. That's the parahippocampal gyrus. You have abnormalities there. So the MRI, there will be hippocampal atrophy, increased T2 signal within the hippocampus, and the MR spectroscopy helps you in lateralization of the focus. You can tell the surgeon, is it from the right side or is it from the left side? Okay? Associated with early childhood convulsion, a prolonged febrile convulsion, early childhood, and epilepsy of extratemporal etiology, and 40% of cases are refractory to medical treatment. For example, you can see here, this is a typical case of MTS. There is atrophy of the parahippocampal gyrus with increased T2 signal intensity. You can compare the temporal horn of the lateral ventricle on both sides. You can see here it's more prominent, indicating atrophy in the parahippocampal gyrus. When you do an MR spectroscopy from the right and the left, you can compare. This is the NAA peak, the choline, creatinine. Again here, NAA peak, choline, creatinine. Which one do you think is abnormal? Of course, left. The NAA peak should be 1.5 to 2 times the level of the choline, which is like the case here in the right side. While on the left side is markedly decreased, indicating this side is abnormal. You can tell the surgeon you can go on the left side and you do your job, and we hope it will improve. Lateralization. In hypoxia, MR spectroscopy can be helpful because due to insufficient oxygenation, there will be anaerobic gliosis causing accumulation of lactate. As we said, anaerobic metabolism, lactate will accumulate. Asphyxia, near drowning, cardiac arrest, respiratory failure, stroke, TIA, trauma, all are causes of hypoxia. Potential for prediction of impaired neurologic function are the NAA and lactate peaks, and for monitoring of therapeutic intervention. NAA levels may continue to decline several days after the acute insult. So there is an acute insult, there is hypoxia, the NAA peak will start to decline, and you can use MR spectroscopy to monitor the response to treatment. Is it increasing again, continuing to decline, stabilized? You can tell the treating physician what's going on. Is the patient responding or not? For example, you can see here, there is a lactate peak, the choline, creatinine, and AAA. So the NAA, obviously, it's little bit than should be. It's still good, but decreased. Should be 1.5 to 2 times the level of choline. Okay, and this abnormal lactate peak indicating anaerobic metabolism in this part that is infarcted. So on follow-up, the NAA should either continue to decrease if there's like necrosis due to ischemia, okay, or it should increase if there is reversibility of the ischemia. Gradual decrease in NAA peak occur over up to 2 weeks, as we said. The window of therapeutic intervention is much longer than we think. What does that mean? MR spectroscopy showed us that previously we were thinking that there's like golden window for treatment of, some people say 4 hours, some people say 6 hours, some people say 12 hours. You can do thrombolysis or thrombectomy in this golden period. However, MR spectroscopy showed that for weeks after the original insult, the NAAP can start to increase, indicating increased neuronal integrity. Yani the body is healing itself, the brain is healing its neurons. Okay, so this is still under research till now, but it indicates that we can treat for a much longer period than we thought previously. Okay, yeah, the brain heals itself over a longer time, gives you a lot of time to treat, not like we thought previously within a few hours and that's it, brain is dead and we can do nothing about it. This is one of major research advantage of the MR spectroscopy. This is subacute stage. You can see there are different voxels. The B, the area of the B is here, showing this inverted lactate peak, and the NAA is relatively normal, maybe mildly decreased compared to the area C here, the adjacent area. The NAA is higher. Okay, there is some lactate peak. So this indicates that this part is more hypoxic than this part. Okay. Regarding neonatal hypoxia, the oxygen deficiency results in insufficient oxygenation. For example, due to umbilical cord compression, the level of lactate is important and determine the prognosis of the infants. What you in neonatal hypoxia, if you do an MR spectroscopy, you focus on the level of lactate. Is it decreasing, increasing? It will predict the outcome of this neonatal hypoxia. For example, in this case, you can see the NAA, the lactate, choline, and creatinine from this voxel here. Okay. You can see the lactate is increased, indicating anaerobic metabolism in the basal ganglia. On follow-up images, you can see there is T2 abnormalities due to basal ganglia ischemia and infarction. Okay, so the appearance of lactate peak indicating poorer prognosis. Okay, and the brain has gone into an anaerobic metabolism due to hypoxia that's strong enough to cause brain death, or part of the brain to be dead. Okay. Regarding Alzheimer's disease, it usually develops in adults older than 60 years. Most common kind of dementia causing memory loss and learning difficulties, senile dementia, it will show the loss of neurons, decreased neuronal integrity, obviously decreased NAA peak, okay? Decreased glutamate due to reduction of the neurotransmitter, and increased myoinositol and choline. An interesting information I was reading a few days ago, some not related to the subject. Previously, they were thinking that smoking helps to prevent Alzheimer's disease. However, recent research shows it increases dementia and increases the development of Alzheimer's disease. And the previous researches were supported by tobacco companies. Okay, just new information. However, it's proven to have a good effect on inflammatory bowel disease, decrease the incidence of Parkinson's disease, and can help in hypersensitivity pneumonitis. So still have some benefits, let's say. Anyway, Alzheimer's disease, you can see here, no lactate, no lipid peak, so there is no anaerobic metabolism. However, we have decreased NAA peak compared to choline, and there we have myoinositol, and there is another creatinine peak. These findings are suggestive of Alzheimer's disease. Of course, you correlate it with the brain MRI that should show diffuse brain atrophy, mainly in the parietal and the temporal lobes, and the usual findings. Again, as with Alzheimer's disease, you can see the NAA peak compared to the choline and creatinine, mildly decreased, not very well. However, there is appearance of glutamine peak here and very small lactate peak. Okay, we should not have this lactate peak, but here it appears. This is a case of S dementia complex. You can see compare the NAA to choline, it's not more than 1.5 to 2 times, indicating decreased NAA peak, indicating loss of neuronal integrity, loss of neurons, which means Alzheimer's disease. Okay, and the myoinositol peak is increased. So, increased myoinositol seems to differentiate Alzheimer's disease from other forms of dementia. It's more commonly seen with Alzheimer's disease. Okay, when you see myoinositol and the patient is demented, it indicates Alzheimer's dementia rather than other types of dementia. In MS, there are white matter lesions shows decreased NAA with either chronically or as a consequence of neuronal or axonal loss, or transiently as a consequence of neuronal or axonal dysfunction. The choline increases in the acute lesions and the micromolecules increases in the acute lesions. The normal appearing white matter will show decreased NAA to a lesser degree and usually reversible as a consequence of transcallosal axonal dysfunction. When the corpus callosum is involved, there will be callosal dysfunction leading to decreased NAA peak that is reversible. Okay, obviously, since it is demyelinating, there is loss of neuronal integrity. It will cause decrease in the NAA peak by definition here. You can see here, this is a case of NAA with an active plaque showing the choline and creatinine, they are normal looking. The NAA is decreased and there is an appearance of a lactate lesion. Compared to the normal side, the NAA is normal compared to the choline and lactate. So, case of suspected MS with decreased NAA peak indicating a demyelinating disease, an active demyelinating plaque. Okay? You can see here, this is typical case of MS. And you can see here, the NAA is decreased and there is appearance of a lipid lactate lesion indicating active disease. We said previously, everything causes decreased NAA and decrease, so you cannot use it to diagnose. It just help you, guide you, direct you to certain diagnosis rather than other. You need clinical data, you need MR images, you need CT images, you need everything. It's just an accessory, the MR spectroscopy. You cannot depend on it to diagnose anything. Okay? Keep that in mind. Everything causes decrease in NAA peak. So, in some metabolic diseases, it has a limited role in the detection of the underlying defects, for example, proteins, enzymes, neurotransmitters. The visualization of the secondary changes can be expressed as neuronal dysfunction, damage, demyelination, gliosis, and monitoring of therapeutic intervention. Regarding metabolic diseases, it shows increased lactate in mitochondrial disorders, increased NAA in Caravan disease. This is the only disease that causes increased NAA. So it's like the easiest. When you see increased NAA, this is Caravan. That's it. Game over. Okay? Increased glutamate, decreased myoinositol, and choline, chronic hepatic encephalopathy, blah, blah, blah. No one will memorize this until you're like a spectroscopy specialist. So just don't pay attention to it. Maybe when you need it, you can visualize this slide and see what's wrong. In general, metabolic disease starts as a gene defect, enzyme deficiency, leading to biochemical dysfunction. Here, the MR spectroscopy is useful. Okay? This biochemical dysfunction causing unhealthy cell, dying cell, no cell, organ failure. Here you can see the CT and MRI. So, the MR spectroscopy will give you changes much earlier than the CT and MRI images. That's a helpful point. So the MR spectroscopy, it will reveal disturbance in the neuronal and axonal degeneration. It's complementary to MRI, but independent. It can be used to monitoring the therapeutic trials, more sensitive than MRI for detection of neuronal damage, and it's useful in differential diagnosis. For example, in mitochondrial disorder, it's the source of energy. The mitochondria are the source of energy. So it detects defects in the mitochondrial enzymes will affect regions with high energy demands, like the basal ganglia. The first part that will be involved, the one that needs energy the most. So in the laboratory, it will show you lactic acidosis, red fibers in the muscles, and spongy degeneration of the brain. This image here was adopted from when I was in Zurich University Hospital. They showed us this image. It's low quality because This MR spectroscopy was done in the late 80s. So when we are still here looking into it and looking how to do it well, in the 80s they were doing this MR. It's not a new technique. It's relatively old now. Okay, Leigh's disease shows marked increased lactate and decreased NAA with small choline and creatinine. So that's why it's a low quality image. Forgive me, but it's a very old image. Peroxisomal disorders. Peroxisomes have a very important role in the variety of anaerobic and catabolic reactions. So the defects of or absence of enzymes of peroxisomal origin will cause migrational anomalies, delayed myelination, demyelination, cranial and peripheral neuropathies, multisystem disorder involving liver, kidney, adrenal, bone, and eye. For example, in Zellweger syndrome, also known as cerebrohepatorenal syndrome, causes growth failure, seizure, dysmorphic facies, deafness, congenital cataracts, things like that. This case of Zellweger syndrome, and you can see there is abnormal spectra here showing decreased NAA peak, okay, and the short arrow, and increase in the choline here. Till now, it consists with just a normal infant. Okay. However, there is glutamine and glutamate elevation and myoinositol disturbance. These are features common in Zellweger syndrome. The glutamine, glutamate, and the MI, the myoinositol peak. These are consistent with metabolic disorders. We have classical X-linked adrenoleukodystrophy, resulting in adrenal insufficiency, behavioral disturbance, seizure, decreased vision, gait disturbance, spastic quadriparesis. You can see here in the adrenoleukodystrophy, there is the NAA peak is a little bit decreased. There you have glutamine, myoinositol with some lipid lactate peak indicating abnormal metabolism. Lysosomal disorders, the most famous one is Caravan disease, although it's very rare. Due to aspartoacylase deficiency leading to increased NAA peak in the plasma. Manifests as hypotonia, poor head control, decreased motor activity, irritability, blah, 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 all common to all metabolic disorders. I hate these, but it shows you a markedly, hugely elevated NAAP compared to the other metabolites. This is typical of Canavan's disease. Okay. Again, another case of Caravan disease. You can see there is a markedly elevated NAA peak in a child that should have a low NAA peak normally. Get it? This is a case of creatine deficiency. Creatine used as a control for the other metabolites. However, in this rare case, you can see the NAA and the choline are relatively normal. The NAA is about 2 times the peak of the choline, but the creatinine is lost, indicating creatine deficiency. It's a rare metabolic disorder. So regarding metabolic disease, spectroscopy is used for follow-up, not for diagnosis. All of them will lead to decreased NAA, except Caravan's disease. So in conclusion, MR spectroscopy is a non-invasive tool for obtaining data in the cerebral metabolism. Its clinical impact is in the differential diagnosis, histology grading of intracranial space occupying lesions. Also, it's utilized in the lateralization of epilepsy and evaluation and the prognosis of asphyxia. It can help in differential diagnosis and monitoring of progression and treatment response to metabolic disease. At the end, again, never ever interpret spectrum without having a brain MRI image, without having sufficient clinical data, lab test. You are a clinical radiologist. We are not a photographers. We need all the clinical data to give appropriate diagnosis and or differential diagnosis. Okay? Thank you very much. Any questions? Good.